based back into a fundamental research group here in Microsoft, who were able to tune the tools and develop the technologies further. Thank you for listening.
Great, thanks very much there to Ian and Chris. So we're going to stay on a health and medicine theme now as well, and moving into thinking about analysing and better understanding the outcomes of medical imaging. And in fact, when I was an undergraduate project of mine years ago was looking at positron emission tomography, so I had early exposure to medical imaging as an undergraduate. So the field's obviously moved on a lot now, as we're going to hear now from Antonio Cremonesi, who works with computer vision. So over to you, Antonio.
Thank you very much. So my talk is a very natural continuation of the talk that you just heard. Natural continuation both in terms of the techniques employed, which are all heavily based on machine learning, and in terms of the medical application involved. But as mentioned earlier, it will be much more focused on imaging. Medical images are acquired every day in all hospitals around the world. And for most of us, they are connected with sad thoughts, because if the most common reason for taking images of the inside of your body is because there is something wrong with your body. But this also gives us a great opportunity of doing really useful science that is really useful to try to make people's lives better, the life of people that suffer the most. It so happens that this sort of science is also very interesting from a technical point of view, from a theoretical point of view. In the medical imaging team here in Cambridge, we do a little bit of a mix of theory and practice as well. So as you will see hopefully in the slides, we contribute to advances in state-of-the-art machine learning, but at the same time we try to focus our attention on the analysis of medical images, which is very challenging because those images are big. There is a lot of data that needs to be transferred around, that needs to be interpreted. The type of work we do here, I'm just going to give you a very kind of quick flavor of the type of research we do and also the vision we have for the future of this type of science. The research we do can be categorized into these three different areas: navigation and inspection of images, quantification, measuring how big a tumor or a different type of lesion is, and also trying to help doctors with their diagnosis. I should say straight away that here we're not trying to replace doctors, because I don't think we will ever be able to do that. But what we want to do is to create tools which can enable them to do their job faster and possibly better as well. But one thing which is important, is becoming more and more important, is to educate the patients as well. Why is it that many of us can't quite understand what those medical images look like? There is a typical example when my wife is pregnant right now, and when the doctor takes a scan of the baby inside, most of us just can't see where the head is, where the arms are, and everything else. So there is a famous episode in Friends, which I love, where Rachel says, "Oh, I cannot see that peanut." Why is it? Well, because we are not used to looking at those images. We are very used to interpreting holiday snaps, and we know exactly where the tree is and where the face is and whose face that is, and that very quickly reminds us of the wonderful time we had in Spain or whatever. But medical images is all a different ballpark. You need to have medical degrees and all sorts of things. But why is it? Well, because we haven't been exposed to those images, and because the tools which today exist for interpreting those images are very crude. Despite the fact that in hospitals nowadays you find multi-million machines like CT scanners, PET scanners, MRI machines, and the state-of-the-art in the hardware for acquiring those machines has evolved dramatically, incredibly. We're still very much behind in terms of interpreting those images, both us as non-medical experts interpreting those images, and also the computer interpreting those images. Like if I told you that in these images there was a problem in the liver, and this problem is called hemangioma, well, still, first of all, I need to figure out what I'm looking at. Then I tell you, okay, this is the liver. And then you start squinting your eyes and looking a little bit more carefully. But still, it's very difficult to figure out where the problem is. So let's see how our technology can help you with this. Well, in terms of educating the patient, we can do something like visualizing images in a colorful 3D rendering sort of way, which is nothing particularly new. But what we have done in this team is making this sort of visualization, which is a lot easier for all of us to interpret, available very cheaply. So cheaply that, in fact, this sort of rendering techniques can be run off your laptop without using much computational power or your telephone. And why is that? Because we have come up with a simple way of generating, of doing all the computation that is necessary for this 3D rendering on a GPU server farm. And then all the image data, once it's rendered, once it's generated, can be transferred to any lightweight device. So this is the first sort of graphics-like innovation. But let's move towards automatic interpretation of images, which is really my background in terms of computer vision. So what we have done is we have created a system, an algorithm, which is based on machine learning techniques, just like Chris Bishop was mentioning earlier on, which enables us to completely automatically, given the CT scan, the 3D image that you saw earlier, figure out where all the different organs are. The computer automatically knows where the left kidney is, where the right kidney is, where the liver is, and so on. And if we have such a system, then what I can do is very simply click on where it says liver, and the system navigates me, hopefully, into the liver. Right now that I know, where the liver is, I don't need to download the entire patient image from what is called a PACS database, the PACS server. I can just crop that section of the image. I can transfer it very efficiently over a limited bandwidth network, and I can now inspect the liver. And now I notice this little bubble, which is the hemangioma in the patient. So you can see how these sort of techniques can help enhance the efficiency of image navigation and browsing. And they can be useful both for experienced doctors and for non-experienced people, like the patients themselves. And by the way, there is a lot of evidence in the medical literature which says that the more educated the patient is, the better the outcome, the clinical outcome. A very simple example, if I'm a smoker, which I'm not, and my doctor tells me, oh, look, you have to stop smoking, then, okay, yeah, sure, I know I have to stop smoking, but it's difficult to do, so I'll probably not do it. But it so happens that if the doctor shows an image of my chest to me, in comparison to a healthy, set of lungs by, from someone else, then I can actually visually quantify, the difference and say, oh, I can see what the problem is, I can see how big it is, I better change my lifestyle. And the same applies to, cholesterol in the coronary arteries and so on. So there is a lot of, very good evidence for that. So now that, now we can put everything together. We can put the 3D rendering together with our semantic navigation into, one single application, which, by the way, is now part of a Microsoft product, as Andrew Blake was mentioning earlier. It's called Amalga. And it is sold to hospitals, and this is something that radiologists love, and they've been asking me to produce for them. So there we have it. There is another interesting aspect to all this. What is an image? An image is nothing but a document. So normally we're used to thinking about documents in terms of written text, such as this. This is a radiological report which says, in different paragraphs what's wrong with the patient where. An image is also a document. It's just much more difficult to read and to interpret. But all the information is in there. All the information that is made explicit here in terms of text is also present most of the time in the image itself. But you know what? If we can do semantic understanding of portions of images, in this case medical images, then we can turn an image into a text. We could even think in the future of extracting this sort of radiological report automatically. I'm not saying that we're there yet, But what we can do today is we can link, hyperlink if you want, text with images. So now in the Amalga application, we have both the images. In this case, we're visualizing the left kidney of the patient in this computed tomography scan and the associated radiological report. And you would have noticed that some words are highlighted in blue because they've been automatically hyperlinked. So if there is a word says cardiac, we know automatically, of course, that that means heart. We can click on the word cardiac, and you get an optimized, zoomed-in, nicely cropped view of the heart. And the same for hepatic, which means liver, and the same for renal, which means kidneys, and so on. Again, to facilitate a very quick browsing of the patient data for both the doctors and the non-expert people. How does all this work? Again, by using the power of data. If this is, imagine a CT scan, what we want to do, again, different 3D visualization, which is made non-transparent, so we look at it from the outside. What we want to do is automatically interpret what's inside, where the different organs are. Perhaps even segment, delineate the organ and separate each organ from the neighboring organs. But how can we ever do that? We know that in traditional computer science, we can write very long programs with a lot of if statements. Say, if this pixel looks bright, then probably it's a blood vessel. If it is dark, then it's probably air. But then there are so many exceptions, so many variations. There is so much noise in the image that this sort of approach never works. Machine learning, instead, is based on the idea that we can learn how to capture the essence of an object or an organ, perhaps in images, by looking at hundreds, if not billions sometimes, of images which are associated with labels. So what we can do is we can use what's called ground truth, or if you want, training data. So this is a CT scan of a patient where someone has gone through the pain of painting the different organs with different colors. Okay, that was me, and it was well worth the effort. It's a very painful task to do, but once we have hundreds and hundreds of these sort of patient scans annotated this way, then we can learn our favorite machine learning algorithm. Again, in this case, we make sure that the algorithm itself is extremely efficient. It scales up very well with data, and we can then, on a previously unseen patient, infer where all the different organs are. So in this case, you see the green area here indicates the left lung, which has been cropped by the image about halfway, but we can still figure out where it is. Earlier you saw the green probability mass for the liver, and you can do this in turn for all the organs that interest you. Once you have this information, then you can straight away automatically raise some alarm, say, oh, the heart in this patient is particularly large. The density, the tissue density, of the liver is higher than it should be, or in the kidneys. So perhaps that's an indication of calcification or other types of lesion, which a doctor might miss out, especially if they're very small. The underlying technique and the algorithm is something that is very, very similar to the engine which underlies Kinect. You will hear more about Kinect. Both projects, the medical project and the Kinect project, share a lot of the underlying technology. The underlying model is called random decision forest. And what's interesting is, as I was mentioning earlier, that the two projects have been enriching one another. And in both camps have been making progress, not just in the application per se, but also in the overall machine learning principles that make everything work. I'm not going to go into the details of that anymore, but talking about Kinect, are there other applications than gaming? There are many. You've seen some demos earlier on this topic. Another one which is of great interest is in the operating theater. A surgeon is operating on a patient, cutting up different bits and pieces, but quite often, depending on the type of surgery, the surgeon also refers back to some reference images, scans, for instance, that were acquired before the patient went into the operating theater. because I need to know, where things are, whether they have moved, where is better for me to cut open, and so on. But remember that in an operating theater, everything or almost everything is sterilized so that, to avoid contamination. So a surgeon has got gloves and perhaps he's holding a scalpel. At the same time, he wants to manipulate the patient images, move them around, go to the previous one, or zoom in, zoom out. So the way it works right now, because he cannot touch a mouse or a keyboard, is he gives instructions to a nurse or someone else. But unfortunately, natural language only gets you so far. At some point, I really want to zoom into a very small area, like almost a single pixel. So doing that by natural language is very difficult. And so how can we cure this problem? We do it by using Kinect. So there is a Kinect camera looking at the surgeon. The surgeon doesn't need to descrub or change into normal clothes again. Just by using his or her hands, he can manipulate a very complex image viewer, such as this 3D CT scan viewer. So very quickly moving to the second part of the talk, I wanted to mention a few things around the area of measuring. So for the less fortunate people that suffer from, say, tumors or other anomalies, like it could be an aneurysm or other lesions, you might know that an oncologist doctor would tend to come up with measurements of that tumor, trying to assess whether the lesion has grown or has shrunk with respect to the previous week, whether the therapy is working or not. But unfortunately, the measurement techniques that they use are very, very crude, and everybody knows this. So according to some well-known international guidelines called RECIST, what you do is you visualize a tumor in a 2D slice, and that's the first big flow with the procedure. And then you measure the longest dimension of this shape, which is completely included within the shape itself. And so you say, okay, the tumor is 2.3 centimeters. Clearly, it should be a volumetric measurement, if anything else, but it is a linear measure. And the problem with this linear measure is that if the tumor deforms, grows, or shrinks, for instance, in this way, the measure itself wouldn't change. It still is 2.3 centimeters, but clearly a lot of change has happened in the tumor. So the measurement does not reflect at all the fact that the therapy might be working or might not be working. So that's a big, big problem. So what we do instead is this is an interactive assisted technique whereby, again, we look at the three-dimensional CT scan in three different orientations, and we can interact, on one of these 2D planes by, the green brush that you just saw, and that is enough to give me a full three-dimensional segmentation of different organs. We saw the kidney being segmented in green earlier, and now the spleen. So all of this is now done extremely efficiently. Now that we have this information, I can measure the volume, for instance, of that organ. I can straight away say not only that the spleen is larger than it should be, which is a well-known possible condition, but also exactly how much bigger it is than average, for instance, or whether it has grown or shrunk with respect to the previous month, and exactly by how much. Right now, it's all done by eyeballing. Oh, it looks like it's growing, it looks a bit different, but how much? So quantifying visual information is a very, very important and difficult task. So remaining in the region of, in the same topic of quantifying, again, cancer patients, they get admitted to hospital maybe every week, every 2 weeks, and every time they go in there, a new CT scan or MR scan is acquired, and things change. The patient is in a slightly different position, or sometimes his intestines are full of food, or sometimes they're not. A lot of things change. How can we isolate the normal physiological changes from the abnormal ones, which are perhaps due to a deformation, anomalous deformation of some organ, or the growth of a lesion, and so on? So I'm illustrating this with a toy example. It's just an illustrative example. So we have a kidney shape, a patient image being acquired in two different time points, and something has changed. So you can probably notice a little bulge here and here. And what normally doctors want to do in order to figure out exactly what has changed and by how much is register these two images, right? So now that the two images are kind of overlapping, you can really see the difference between the two. And again, you can quantify these differences and measure them. In principle, applying this registration is just a simple mathematical transformation that gets applied to the image pixels. In practice, making it work really well, really robustly for all patients, for all types of medical images, and there are many, it is very, very difficult. Despite about 4 decades now of research in that area, no one can say that the problem is solved. And what we've done is, by training our system, by looking at a lot of data and using the probability of different organs being in different places, we can achieve this registration a lot more robustly than the state-of-the-art algorithm, which translates into much lower errors. This is the blue curve compared to the best state-of-the-art. In this case, lower means better. Finally, a little bit of the future, our vision for the future. It would be great to be in the future in a situation where we can, as easily as nowadays we search the web, we can search our own body for problems, for instance, or for healthy organs as well, but get a quantitative evaluation of how well our body is working, what is not working so well, how can I change my lifestyle in order to improve my life and my health. So, of course, we're not there, but that's our ultimate goal. And in this sense, we are working already in terms of doing like a visual search engine. This is some work in collaboration with the University of Oxford. It's all cloud-based. You can play with this yourself on your Internet Explorer web browser. And what you do is you have patients' images in front of you. You select, say, a vertebra. And what you want to do is you search through thousands and tens of thousands of patient images of all sorts, different types of images. Not only you want to retrieve similar images like spines, but also retrieve exactly the same structure as you have highlighted in the query. Why is this useful? Because doctors can learn from the history of past patients. What has worked for the majority of them perhaps will work for the patient I have in front of me. Other things we're working on is cardiac diseases. This is in collaboration with the InnerEye Institute in France, in Sophia Antipolis, which are experts in modeling hearts. And what we can do is we can look at 4-dimensional images. So these are 3D images of the heart, plus time. So you can see the heart beating. And finally, we're working with the Addenbrooke's Hospital here in Cambridge on trying to help oncologists do a better diagnosis for certain type of brain tumors. It's not enough to just say there is a tumor or there isn't a tumor. It's very important to separate the different sections of that tumor into what's called the proliferating edge, the necrotic core, which is the already dead part of the brain, and the infiltrated area. This is mostly made of healthy cells, which are probably swollen up, but also there might be some infiltration of nasty tumor cells as well. So if we have all this information, for instance, the radio-oncologist can plan the best course of radiotherapy treatment, taking into account the margins of this uncertain region as well. So I hope I haven't bored you too much and you found this interesting. That's all. Can I give this to Sharon?
Antonio, thanks very much. Okay, and we are bang on time as well. Fantastic. So we've got about another half an hour to go, and Antonio was talking about a load of themes there, but he also touched on InnerEye's natural user interfaces to help doctors or even lay people make sense of these